What are the different types of fungal infection? Tinea capitis, scalp hair, thinning scalp hair, scaling and broken hairs, and alopecia we can see. Tinea corporis is in trunks and limbs. It is an scaly region with central clearing. Tinea cruris growing region में itchy erythematoscaly plaques. Tinea pedis feet interdigital scaling, fissuring or mucus in pattern. Tinea manum hands dry scaling, often unilateral. Tinea facie, tinea in face and erythematoscaly lesion. Tinea barbae, beard area, inflammatory follicular infection. Tinea inguinum, onychomycosis, nails, thick discolored brittle nails. Other common superficial fungal infections, candidiasis, oral and genital intertriginous areas. Pityriasis, versicolor tinea, versicolor malassezia peripheral fungi, intertriginous candidiasis. What is the exam classification we have to remember? Exam classification that we have to remember, that we can write in exam classification. Classification, what right here? Superficial fungal infection, dermatophyte, skin, scalp, skin, nails. In scalp it's called tinea capitis, in skin tinea corporis, tinea cruris, tinea pedis, tinea manum. In nails, tinea onychomycosis, and yeast. Yeast is Candida malassezia furfur. This Candida and malassezia furfur. So these are the different types of fungal infections in general practice. Which one? Tinea capitis, tinea corporis, tinea capitis in head, tinea corporis in body, tinea cruris in growing area, tinea unguum in nails, tinea pedis in feet, tinea manuum in hands, and tinea facie in face, tinea barbae in beard area. What are the other common superficial fungal infections? Candidiasis, oral genital intertriginous, pityriasis versicolor, which is called malassezia, intertriginous candidiasis. Exam superficial fungal infection, dermatophyte, skin, scalp, nails, scalp in capitis, skin corporis, cruris, pedis, manum. Then nails, yeast candida, malassezia. What is the approach to a patient with tinea cruris? Okay, second question is, what is the approach to a patient with tinea cruris? So let's discuss about approach. First we will ask for history, then examination, then differential diagnosis, then investigations, then treatment. The 5 points we will know. So let's first discuss about flow chart. What flow chart is showing? Management flow chart. So this is the flow chart. Itchy growing rash, tinea cruris, history plus examination we will do. And typical tinea cruris is there. Then we can recognize yes, topical antifungal, no. Keywords and further evaluation. If topical antifungal is given, assess response plus look for infections as well. Response, look for infections as well. Improving complete course and prevention. Persistent and recurrent type diagnosis. KOH culture systemic therapy. Treat reservoirs, feet, nails plus treat reservoirs, feet, nails plus review. Review. So itchy growing rash is there. There is a history plus examination. Typical tinea cruris, yes. If not, then we can evaluate keywords of other evaluation. Typical is there, we will diagnosis topical antifungal. Assess response plus look for infections as well. Response plus look for infections as well. Improving the complete course plus prevention, persistent recurrent, persistent recurrent check diagnosis, KOH culture or systemic therapy, treat reservoirs, feet and nails, and review. So let's discuss in deep. Examination. Typical tinea cruris. What history we will ask first. Symptoms, ask about itching, usually prominent. Long duration and progression, burning or pain, recurrence, discharge or order, similar reasons elsewhere. These are the symptoms we will ask about. The predisposing factor, excessive sweating, hot and humid environment, obesity, diet occlusive protein, diabetes mellitus, immunosuppression, sharing towels and protein, contact with infected household members, associated tinea pedis or onychomycosis. Specifically about athletes because the feet may act as a reservoir for recurrent ongoing infection. So, and treatment history as of previous antifungal use, topical steroid use, steroid antifungal combination cleanings, previous treatment failure. So in history we will ask about symptoms, predisposing factors and treatment history. And symptoms we will ask about itching, usually prominent, duration and progression, burning or pain, recurrence, discharge or other similar lesion elsewhere. What are the predisposing factors? Excessive sweating, hot and humid environment, obesity, tight and occlusive clothing, diabetes mellitus, attainment of humid environment, tight occlusive clothing, immunosuppression, sharing towels and clothing, contact with infected household members, tinea pedis or onychomycosis, tinea pedis, onychomycosis. But at least the feet may act as a reservoir for recurrent growing infection. What is the treatment history? Ask about previous antifungal use, topical steroid use, steroid antifungal combination, antifungal combination creams, topical steroid use, steroid antifungal combination creams, previous treatment failure, previous treatment failure. What are the examinations from? Typically, look for well-demarcated erythematous plaque, demarcated erythematous plaque, scaly advancing age, central clearing, itching, usually bilateral but asymptomatic, external to upper inner thigh. Clinical classical inclusion spares the scrotum. Removal of candidal intratrial. Classical tinnitus will generally spare the scrotum. If the scrotum is involved, consider candidal intratrial. If scrotum is involved, then we can consider candidal intratrial. Examine other sites. Examine other sites. Look at feet. Sides look at feet, nails, scalp, other body surfaces. Look at feet, nails, scalp, other body surfaces. So example typical is well demarcated erythematous plaque, is and scaly advancing age, central clearing, itching, usually bilateral but asymmetric, external to upper thighs. Clinical classical tinnitus generally spares the scrotum. If the scrotum is markedly involved, then considered as a candidal intratrial. Examples look at feet, nails, scalp, other body surfaces. Differential diagnosis: candidal intratrial, moist erythema, satellite pustules, scrotal involvement. Moist erythema, satellite pustules, scrotal involvement. Polythrasma, brown red lesions, coral red fluorescence with false line. Inverse psoriasis, smoothly shiny subdermal erythema, little severe neuritis, other typical subject sites, spontaneous exposure related to often poorly defined intratrial, mostly moist inflammation in skin folds. The different diagnosis: candidal intratrial, inverse psoriasis, contact dermatitis, intertrial, erythrasma, seborrheic dermatitis, seborrheic dermatitis. Investigation. Tinea pubis is often a clinical diagnosis. QH a clinical diagnosis. QH microscopy. QH diagnosis uncertain treatment fair. Skin scraping from the active scaly age. QH preparation. Suspected branching fungal hyphae. Fungal culture. Considering diagnosis is uncertain. Recurrent infection. Treatment failure. Extensive disease. Immunocompromised patient. Setting of disease is often a clinical diagnosis. Skill microscopic diagnosis uncertain. Treatment failed. skin scraping from active scaly, cures, purification, cells, accelerator. Branching fungal hyphae, level diagnosis is uncertain, recurrent infection, treatment failure, extensive disease, immunocompromised patient. The treatment we will do generally keep growing area dry thoroughly after bathing, wear loose and breathable cotton clothing, change underwear regularly, avoid sagging towels and clothes, avoid occlusive clothing, treat coexisting tinea pedis and onychomycosis, address obesity and excessive sweating where relevant. Topical antibiotic first line. For uncontrolled localized disease, terbinafine 1%. Applied to affected area and surrounding skin once or twice daily. From the powder, regimen 0.1 to 2. For topical azoles, propiconazole, miconazole, ketoconazole. Surgery required treatment for 2 to 4 weeks depending on preparation and clinical response. Under treatment for recommended duration even after symptoms improve. Mandatory duration of symptoms. Systemic antifungal therapy. Treatment general measures, topical antifungal therapy first line. Systemic therapy. Consider oral therapy when extensive disease, severe inflammatory infection, recurrent infection, failure of adequate topical therapy, immunocompromised patient, associated extensive dermatocytosis. Extensive dermatocytosis. Option A, terbinafine or itraconazole with drug interaction, produces either drug before prescribed. Itraconazole with drug interaction and liver disease and other contraindication can be considered before prescribed. Or steroid antifungal combination cream. Topical prophylaxis is generally available. This must be remembered. In any fungal infection like tinea crawlis, we have to avoid steroid antifungal combination cream. Avoid steroid antifungal combination cream. May be avoided in suspected infection, particularly potent steroid antifungal combination. They may mask the characteristic appearance, promote fungal proliferation, cause tinea incognito, produce recurrence. Okay, so this is the very important line you have to remember. Avoid steroid antifungal combination creams should generally be avoided in suspected dermatocyte infection, particularly potent steroid antifungal combination. They may mask the characteristic appearance, promote fungal proliferation, cause tinea incognito, and produce recurrence. Okay. So, measure flow chart we have already seen. One figure, examination figure. Let's draw the figure. If lower abdomen is the growing area, scale, central clearing, thigh, raised up to a scaly margin. Scaly margin. Let me show you the figure. If lower abdomen is there, growing in these growing areas, scale, central clearing is seen. So thigh region is also can be expanded. This arrow mark showing raised active scaly margin. practice point we have to remember. Tinea purpura is dermatophyte infection of the growing, usually within each scaly advancing age. Infection of the growing, usually within each scaly advancing age. Examine the feet and nails because they can be reservoirs of recurrent infections. Scrotal involvement. One should make you consider intertrigger. QH microscopy useful when the diagnosis uncertain or treatment fails. Topical terbinafine or an azole. Azole is inappropriate. Most applicable. Consider antifungal for extensive recurrent and refractory diseases. Avoid steroid containing combination creams. They can produce tinea in cold. Keeping the growing area dry, cool and non-ocular is an important part of prevention. There is always search for tinea pedis and onychomycosis. These are key points. What tinea pedis is the dermatophyte infection of the growing, usually within each scaly advancing age. Examine the feet, nails because they can be reservoir for recurrent infection. Scrotal environment should make you consider candidate interactive. QH microscopy is useful where diagnosis is uncertain or treatment fails. Topical anaphylaxis is appropriate for most candidate cases. Consider oral antifungal for extensive recurrent or refractory disease. Avoid steroid containing combination creams, they can produce tinea in publica. Keeping the growing dry, cool and non-ocular is an important part of prevention. In recurrent cases, always search for and treat tinea pedis and onychomycosis. So as we have discussed in approach, we will ask for history, symptoms, predisposing factor and the treatment history. In examination, we will do typical tinea pedis to provide emergency flag risk at advancing age, skin clearing, itching, usually bilateral asymmetric. Classical tinea pedis spare the scrotum. The scrotum is not angular interactive. Examine the sides. You can treat nails, scalp, and body surface. Differential diagnosis. So different diagnoses: candida interactivo, interactivo, inverse psoriasis, contact dermatitis, erythema, seborrheic dermatitis. Investigation: tinea pedis is often clinical diagnosis. Case microscopic diagnosis that depend on treatment phase, skin scaling from the active scaly age. Treatment phase, skin scaling from the active scaly age of proliferation shows septate branching, fungal hyphae, fungal covering, consider and diagnosis uncertain recurrent infection, treatment failure, extensive disease, immunoprovocation. So we can infection, treatment failure, disease and immunoprovocation. General measures keep growing clean and dry. Keep growing clean and dry clothes after bathing. Wear loose and breathable cotton clothing. Change underwear regularly. Avoid sharing towels and clothes. Avoid occlusive clothing. Requires pediatric pedis and onychomycosis. Study obesity and exercise by the relevant. Topical antifungal terbinafine, clotrimazole. Terbinafine 1% of the topical reliance, pharmacy once or twice daily. Open the product regimen usually for 1 to 2 weeks. Or topical drugs like clotrimazole, piconazole, ketoconazole. These will require treatment for total 4 weeks depending on the population and clinical response. Continue treatment for the recommended duration even after symptoms improve. System edible therapy considered therapy when extensive disease, immunocompromised patient, severe inflammatory infection, extensive disease, recurrent infection, failure for adequate topical therapy, and associated extensive dermatophytosis. Terbinafine, etoconazole drug, intestinal liver disease, avoid steroid antifungal combination cream. Topical corticosteroids should generally be avoided in suspected dermatophytosis. Suspected dermatophytosis. fungal treatment. Management we have discussed. Then example we have discussed. In which growing years history examination people in theories. Yes, to the no creative evaluation assess response look for infection elsewhere. Improving common reports prevention persistent events and antibiological system therapy treat observer feed and nails and review. There are activities. Okay, bye bye guys. This is only the education purpose. Bye bye.